We are live, so we're going to go ahead and get started. So welcome everybody. Michael Sapienza. I'm the CEO of the Colorectal Cancer Alliance. We're very happy to have you here with our distinguished panelists for the State of Disparity and Equity Solutions in Colorectal Cancer. So just to highlight, some of you may or may not know this, but April is National Minority Health Month. And I just wanted to highlight a couple of the Alliance programs that we are involved in right now. We are providing free donated Cologuard kits from Exact Sciences, about 1,500 of them, about 15,000 FIT kits, and over $300,000 worth of funding for colonoscopies. We have a community-led FIT kit partner distribution program in Philadelphia. And then we've also have two projects to increase screening rates in Black Philadelphians as well to be replicated in Atlanta. This year alone, just in the first couple of months, we have given almost 7,000 recommendations for screening through our navigation tool and our live navigation. And we did an incredible advocacy campaign called OP45 to speed up insurance coverage of starting screening at 45. So I'm really happy to report we are about 70 to 80% of the way there in terms of coverage. And then last but not least, we have launched the They Didn't Say campaign, which is an influencer campaign that had over 280 million impressions and was really targeted at the African American and Black American community. In addition, we have funded 4,100 financial assistance awards. We obviously have navigation programs and peer support aimed at quality of care, access, et cetera. And we have funded research in disparities as well. So I would like to introduce our panelists, Dr. Carmen Guerra, who is a general internist and health equity researcher. Dr. Guerra is the Ruth C. and Raymond G. Perlman Associate Professor of Medicine at the Perlman School of Medicine at the University of Pennsylvania. Hello, Dr. Guerra.
Thank you, Michael. It's a pleasure to be here.
Dr. Rachel Issaka, a gastroenterologist and a clinical researcher. Dr. Issaka is the Associate Professor of Gastroenterology and Hepatology and the Kathryn Surace-Smith Endowed Chair in Health Equity Research at the Fred Hutchinson Cancer Research Center. Hello, Dr. Issaka.
Hello, Michael. I'm happy to be here.
Thank you. And last but not least, Bridgette McCullough, who is the founder and CEO of ACIRAH, PBC, a health and wellness website. Ms. McCullough is also a senior researcher at the Feinberg School of Medicine at Northwestern University. So the first question I have is if the three of you briefly, maybe 2 minutes, could introduce yourself and tell us about your connection to the Alliance, to colorectal cancer in general, and then we will go from there. So let's start with Bridgette.
Thank you, Michael. I'm very happy to be here. When my connection with colon cancer began a little over 2 decades ago with the death of my grandmother from colon cancer, and knowing that there was very little that I could do to help her. At best, all I could do was sit at her bedside and just watch her just die. About 6 years after that, I was a graduate student in a PhD program at U of C at the University of Chicago, and I was diagnosed with colon cancer. But the biggest difference between my grandmother at a community hospital in a Black neighborhood on the west side of Chicago versus my being a graduate student at one of the most elite research institutions, I also was just completely ushered over to the University of Chicago hospitals, where in no time, within about a day, there were 2 GI specialists, there was a reproductive endocrinologist, there was a hematologist oncologist, there was literally a team of about 8 people around me and constantly telling me that, Ms. McCullough, you are going to be okay. You're going to survive this, even though I thought for sure I was going to die because I didn't know anyone that survived colon cancer or any form of cancer. And I did. One of the biggest things that happened was the hematologist oncologist, Dr. Alapade, introduced me to, at the time of the name was Colon Cancer Alliance. And with that introduction and meeting people at CCA, it literally changed my entire life, because there I found people that were not only survivors, because I had 2 cancer buddies, but I had an entire organization that I could lean on for support and resources that I'd never even imagined that there were anything like that at all. So that's my connection.
Thank you, Bridgette. Dr. Issaka.
Thank you so much for sharing that story, Bridgette. My introduction to colon cancer also serendipitously began in Chicago as a resident at the time at Northwestern. And I had 2 clinics. One was downtown Chicago, and the second was on the South Side. And the clinic on the South Side was a federally qualified health center, predominantly Black and Latino patients. And my downtown clinic was predominantly working class individuals who were white. And I noticed the stark difference whenever I would bring up colon cancer screening as part of health maintenance conversations. And that was really what stirred my interest in wanting to understand why. Why were my Black and Latino patients always declining colon cancer screening, whereas my white patients accepted it and would kind of just follow the recommendations. That has since led to my research program, which is built on trying to understand the barriers to screening and improving follow-up as a way to reduce deaths and reduce disparities in colorectal cancer. So I got connected to the Alliance in 2020, initially as a consultant, and then subsequently as an individual on the medical advisory committee. And it's been a really wonderful partnership during this time.
Thank you, Dr. Issaka. Dr. Guerra.
Thank you, Michael. I think Dr. Issaka and I could be professional twins, because I was going to tell the same story about how my first introduction to colon cancer was as I was a final 3rd-year resident at the University of Rochester, and I began to take care of a woman who lived in rural upstate New York and had been diagnosed with colorectal cancer and told to follow up in a clinic. She was assigned to me, resident, and I'll never forget her. She taught me what it was like for her to go through that diagnosis at that time, and I still think about her to this day. And then I came to the University of Pennsylvania as a faculty member, and exactly the story that Dr. Issaka mentioned. I started observing that my patients of color, I would tell them over and over every time they would see me to please go get colon cancer screening, and they didn't. And it wasn't because they didn't want to. Some of them perhaps didn't. They didn't think they needed it. But a lot of them just didn't have the resources to complete that test, whether it was a day off from work, sick leave, or the resources to cover the prep that they needed to pay for out of pocket to be able to go to colonoscopy, or couldn't get through the phone lines, or couldn't get through the 5-page of instructions written for someone with a PhD in my institution. So, after observing that, it really changed my life. I decided that I just could not be only a primary care doctor, that I would go back to school, get a master's in epidemiology, and do something about this problem on a broader scale than just one-to-one. And so with that, I was armed to be able to establish the first colorectal cancer screening navigation program. And that's where my alliance with the Colon Cancer Alliance began. They just were so generous in supporting that program and allowing us to buy that prep for free and give the patient the SEPTA token so that they had transportation to their colonoscopy. And then it evolved since then. And I'm proud to say that I've only begun to work with them closer and closer with them on projects such as the one that Michael was talking about, Philadelphia, which I'm really excited to really participate and support. And so with that, Michael, back to you.
Thank you, Dr. Guerra. So actually the first question is for you, Dr. Guerra, and Dr. Issaka, if you want to follow up, please do. As we all are aware, there has been an increased focus on equity over the last few years. Tell us what this means in colorectal cancer and what health disparities are prevalent in prevention and treatment of this disease.
Yeah, no, thank you. And I couldn't be happier about this increased attention to health equity because, probably like other panelists, And yourself, Michael, we've been worried about this issue for a long time. And finally, it's getting some of the attention. So I guess I would start by saying that, if you look at across all populations, there are some populations that are just going to be less likely to be screened for colorectal cancer, and therefore more likely to bear the burden of this disease. And they include people who are uninsured. As you heard me say from my story, rural Americans, racial and ethnic minorities, as you also heard from my story, immigrants. So there are these populations that just don't have the same access to colorectal cancer screening, and therefore are diagnosed with colon cancer at higher rates, and then often diagnosed at later stages when it's much less treatable. And so that's what health equity means when you look at it in the lens, using the lens of colon cancer. And then the second thing I would say is oftentimes these inequities occur not because we need better science or better cures. It's actually because the science that we have isn't being applied to all individuals, so they all have the opportunity to screen and prevent this disease. And so I think what the problem is now is that we really haven't applied that science, and we really need to apply it in a way that's more equitable to different populations. And that's where the Colon Cancer Alliance comes in, because of its reach, tremendous national reach, and because it knows how to solve that problem. And it can do so by convening the right people, the right partners, obtaining the right resources to be able to have those populations access screening. And I would say, the inequities are pretty significant. There are some populations that are almost 50% more likely to have colon cancer, for example, when you think about those different populations I discussed. And that's a big burden of the disease. And we can do something about that, as I indicated earlier. There are, as you were saying, disparities in inequities in prevention, screening, treatment, and even access to clinical trials. And a lot of times those inequities have to do a lot with the social determinants of health, those conditions in which we're born and live and work. And that includes everything from the education that people get, to the type of jobs that they have. We mentioned, jobs with paid leave, for example, and it includes transportation and access to care. And as we know, those populations have different access to those social determinants of health. And so that's what results in many of the inequities in colon cancer prevention, screening, and even access to clinical trials that we know about too.
Thank you, Dr. Guerra. Dr. Issaka, do you want to add anything to that?
I think Dr. Guerra summed that up really nicely. I would only add that, COVID-19 really unveiled how disproportionately impacted racial ethnic minorities are in this country, specifically from COVID-19, but then really allowed us to place a spotlight on the many other diseases where racial ethnic minority individuals are disproportionately impacted. And so while we've known, for instance, in colon cancer, that the likelihood of dying and even, being diagnosed with colon cancer has decreased by about 50% over the past, 3 decades. The disparities, so the difference between those who are surviving who are Black versus white, who are American Indian Alaska Native versus white, who are Hispanic versus white, those gaps just persisted despite us doing a really great job of bringing this disease down. And COVID-19 allowed us to shine that spotlight to say, well, it's not just COVID-19, it's many other diseases. So, to Dr. Guerra's point, it's not about new treatments, it's about how can we get the care that folks need to prevent disease into their hands right now.
Yeah, that's great. Bridgette, will you touch on just the clinical trial disparities piece? I know you're working obviously very close with that with ACIRAH, so I'd love to hear your thoughts.
Yeah, I'd love to. I just want to go back a little bit to what why the clinical trials is so important. I look at my experience in living on this, I'm on the south side of Chicago, but I'm in Hyde Park. And that's a dramatic difference between the other communities on the south side of Chicago. And in addition to that, I was working on a PhD. So that was the second round of an advanced degree that I was getting. So even in terms of the way that I perceived myself in the world was very different from the way most people who are coming, Black people who are coming from low-income, neighborhoods, and how they're perceiving themselves, and even how the medical professionals are going to be engaging them. So when I'm sitting in the hospital and the way in which all of the doctors and the surgeons and the specialists were engaging with me, not as though I was a colleague, but they did recognize that I was one of them. I was a student at the University of Chicago. I was a part of the community of the University of Chicago, but also the way that I was able to actually speak up for myself. Even though I was speaking to a lot of the fears that I had, I just knew for sure. My grandma died in 95 and it was now 2002. I just knew I was going to die. And even though they were all telling me, nope, this is what's going to happen. We're going to do this. I've done this surgery for 100 times. You're going to be fine. I just thought, oh, they're lying to me, because I'm sure that's what those doctors told my grandmother, that she was going to be okay as well. So when it comes to something like, that's having a disease and then going into a hospital to have surgery, to be taken care of. When you're talking about a clinical trial, you're talking about something that's even more deeply embedded with wounds and a dark history. And now you're trying to get Black people to be okay with getting experimented on, because that's the mindset that most people have. And even of those that are interested, are willing to go into clinical trials, because you don't always have to be at the last stage of life. You can be a healthy person and participate in clinical trials. There you find the problem with the access to the clinical trial to the Black person in the Black community. So after many years and going back to school to get a brand new set of degrees in biotechnology and bioethics with a focus on gene editing and clinical trials, and then going to law school and doing all the work that I did, I went into law school knowing that I'm going to start a company, and I'm going to maybe not be the sole body that solves this problem, but I'm going to make a dent in it. Because if I started a clinical trial recruitment company where the focus was on African Americans, cultivating African Americans to all the benefits of what a clinical trial actually is, what the benefits are, how it can impact the larger outcomes of their health, and how that company could partner with pharmaceutical companies, with other resources out there to some degree decentralize clinical trials and bring those clinical trials into the Black community, into someone's home. You eliminate a lot of the problem of having people not having, the transportation. And so, I don't want to take up too much time, but that's one of several of the issues that we are working to resolve.
I was going to say there's a lot of head nodding in that story, so thank you. Rachel or Dr. Issaka, let's start with you. So according to the most recent American Cancer Society report, a very disturbing statistics related to these health disparities is that Black individuals are 20% more likely to be diagnosed with colorectal cancer and 35% more likely to die from the disease. So why are the incidence and mortality rates of colorectal cancer so much higher in Black individuals? Let's start with you, Dr. Issaka.
Sure. So Black-white disparities have been studied for a long time, and I wish I could say the same for Black American Indian, Black Hispanic, disparities. But when we look at Black-white disparities in particular, we know that about half of the difference between those groups can be explained by lack of screening, and then having a more advanced stage disease at diagnosis. So meaning that folks don't live as long because the more advanced stage disease you have, the more likely you are to not have great treatment options available to you, not respond to those treatments, and therefore not have as long of a life expectancy. So, you know, I think those are really two big areas. And as we've been talking about earlier, you know, there's certainly a focus on screening and improving screening, but there are disparities throughout. So from the time of folks being evaluated for their risk for colon cancer, to when they're getting preventative care, to when they're getting diagnosed, to when they're getting treatment and even surveillance, we see that there are gaps between Black, white individuals along that entire continuum. And so there is much work to be done to close those gaps.
Thank you, Dr. Issaka. So, Dr. Guerra, I've asked you this question before. Maybe you remember, maybe you don't remember me asking you this question before, but, you know, for the Alliance, I mean, one of the things that obviously we are trying to do is have an impact on those numbers, the 20% higher incidence and the 35% higher mortality. And number one, you know, Rachel talked to this, excuse me, Dr. Issaka talked to this a little bit, RE, what are making up those disparities. But do we really know across the board what makes up the full 20% and the full 35%? And let's say we do, or we know some, would potentially the Alliance investing more in local communities, in grassroots projects, in these types of things, like Susan G. Komen has done, like Leukemia and Lymphoma has done, like HIV/AIDS movements have done, would that help us, you know, reduce these disparities? I know those are two, and Dr. Issaka and Bridgette, you can also chime in after Dr. Guerra answers. I know it's a big question.
Yeah, for the first part, do we know what makes up for those large differences in incidence and mortality? I agree with Dr. Issaka. That has been evaluated by multiple investigators. And as she correctly said, a large part of that is access to screening, which is in some ways the good news, because I think we can make a large impact to correct and reduce that gap. And then the other part is presenting patients who present at much later stages, which then impacts their overall survival. And so they end up having a higher mortality. And so I think that's well described, well known, it's been replicated. So you can explain almost the entire gap, the inequity, by those two major findings. And as far as what the Alliance can do to really move the needle, yes, we have, and I remember the conversation about how the Alliance can be most impactful. And I remember the conversation, Michael, being, well, shouldn't we get colonoscopy to everybody, right? Because then you have the ability to prevent colon cancers in a larger proportion of people by removing those polyps, with the exception that not everybody is going to have a colonoscopy for many of the reasons that we already talked about. They may not want to, they may not be able to, they may not be able to take time off of work, for example. They may have conflicts with childcare or elder care. And so for a lot of reasons, not everyone will agree to have a colonoscopy. And so we have to give people the ability to choose what's the best test for them. And many of you have probably already heard the best test is the one that gets done when it comes to colorectal cancer screening. And that allows people to be able to be screened on their own terms. You know, we all have a say in our health and how we want to acquire that health. And so I think we owe people the respect to allow them to choose what's right for them. And for many of them, colonoscopy is not the right choice. And so I think that what we can do is support that individual choice, whatever that choice might be, as long as people get screened. And so for those that don't want to be screened, the Alliance has a major role here. And that's, you know, developing educational campaigns that are effective, not only effective, but inclusive. Mm-hmm. So what's an inclusive educational campaign? Well, it would be one that's not just available in English. And it's one that acknowledges the differences in health literacy by education. And so I would say, number one, educational campaigns that are inclusive. I'd say number two, I would say give people that choice and support it. So if you can provide that fit test in the comfort of people's homes, I heard the wonderful phrase decentralizing clinical trials. Well, we can decentralize cancer screening, and colorectal cancer screening is the perfect way to show that model, to lead that model. And so I would say providing fits, as you are doing in Philadelphia with the Go to Know campaign that I was just so honored to be part of a couple nights ago. And so that's an important step. And then other things like transportation. Black Americans have the highest rate of not owning a car in this country. 19% of Black families do not own a car, which is compares with single digits for the other communities. And so providing means of transportation, a ride should not be the reason why people don't get screened. And then lastly, I would say navigation. And I know the Colon Cancer Alliance provides wonderful navigation. It's being combined with that Go to Know campaign, which I love. But people need, this is a complex healthcare system, and this is a complex screening test, colonoscopy. And so they need help, they need reminders, they need appointments, they need to know how to, and navigation is the way to help. So I would say that that's how I would answer what the Alliance can do. And I know it's already in that space. We just need to scale it up further.
Thank you. Dr. Issaka, if you have anything to add to that piece, I'd love to hear it. But I'd also just ask, in terms of systemic racism in the healthcare system, can you talk a little bit to how that plays into the disparities as well, both in screening and treatment?
Well, we know that historically policies, led to overall Black communities and other racial ethnic minority communities being confined to spaces where they weren't always able to access care, has led to the lack of generational wealth amongst those communities. And again, not exclusive to Black communities, but where most of the research has been done. And we know that this is directly tied to then lack of health insurance. And we know that lack of health insurance is directly tied to poor health outcomes. And so you can almost draw this line between this country's history of racism and policies to then now poor health outcomes today. So what can we do about it? In addition to all of those things that Dr. Guerra mentioned, I think that there is certainly a need for policy that aims to correct these historical injustices. So we are one of the few countries, right, around the world that doesn't have a universal healthcare system. And as a result, care is fragmented. And so, we can't see if somebody, for instance, starts a colon cancer screening, at one state and then moves to another state, if those records aren't directly shared with the healthcare provider. And so I think this is an area where the CCA can be very impactful. I know you all were working in partnership with other organizations like the American Gastroenterology Association and Fight CRC, et cetera, earlier this year, where we were you were able to lobby and negotiate for insurance companies to begin covering screening starting at the age of 45, and to also ensure that people who get a non-invasive screening test do not pay for out-of-pocket cost sharing when they need that follow-up colonoscopy. So I think the CCA has even unlimited potential in this space. How can we lobby for health insurance that's all-encompassing? How can we lobby for health insurance that includes covering these logistic barriers for all patients? How can we lobby for metrics that truly make a difference, not just the first part of screening, but ensuring that the follow-up occurs in the same way that breast cancer has policies supporting it at the national stage? So I'll stop there.
Yeah, thank you. Bridgette, I want to ask you a question about communities. So how, you've had a lot of experience doing this, and now we're getting even more experience, but how do we reach the most vulnerable communities and meet people where they are?
I think that's just it. You have to meet them where they are. Our country could have every bit of the matrix set up, every policy, all the money, all the funding in place. But if it is not where that person is, if it's not in their neighborhood, if it's not speaking to them, if it doesn't even address them as a human being, then these numbers are still going to remain the same. So one of the things that even before the pandemic that we did at ACIRAH is to actually go out to Black communities where they were, from churches. Here in Chicago, we have like the benefit of having Operation Push and all these Black churches all over the place on both the west and the south sides. But going out there into those communities and doing something that even people have said to me that that must be your secret sauce. It's not, but I'll tell you what it is. Meeting people at where they are. I'll look at a company like a Louis Vuitton Moet Hennessy or Gucci, and how every hip hop artist, for every 4 minutes and 32 seconds that they have for their rap songs and their hip hop lyrics, they're like walking ads for those companies. Why? I remember 20 years ago, or when I was a teenager, like 1,000 years ago, they never had ads with Black people in them. Never. It was always something like the Acropolis you have to aspire to get to. But all of a sudden, there's Jay-Z, there's P. Diddy, there's all of them singing the praises of these brands. And what does that mean? Those brands are going to the Source Awards. They're at the basketball events like the Rutgers games, the Marillac House games here in Chicago. They're coming to them. And as a result, it's completely changed their entire business model. So you look at brands like Louis Vuitton and Gucci, it no longer looks like those brands looked in the 70s and the 80s and the 90s. It literally looks exactly like being on 125th Street in Harlem at the height of the 90s hip hop era. So that's what we do at ACIRAH, is to meet them where they are. And not be punitive when you do it, not admonish people, not say you should be doing this and you ought to do this. They're feeling that way for a reason. You have to understand. I mean, if we really know the history of this country with Black people and their health, when you look at large slave plantations, I've done research and spent 4 weeks at Mount Vernon, living on Mount Vernon. There is a slave hospital at George Washington's old plantation. Why? Because he needed to make sure that every one of those Black people, from the babies to the grandpas, were being taken care of so they could be able to do the work that they were supposed to do. The minute slavery ends, now you're a nuisance. So there's no longer a need to keep you healthy. That has done such a deep harm to I would go so far to say not only to Black America, but to this country as a whole. It has damaged this country. You have to meet, and now I'll say this a lot, you have to meet people where they are. So if for us at ACIRAH, what that means is that we have recruited people, over 10,000 people, to be members of ACIRAH. And how do we do that? Because in my previous life, I used to be an art advisor to very wealthy people, most of which we've seen in movies and TV, and with all of those brands. So we've gone out into community centers on both the west and the south sides of Chicago and Oakland, but we've also had events at the Gucci flagship stores in Chicago, Los Angeles, San Francisco, and New York, bringing people out. And what have they done? They've given their products to people for free. They've sent champagne to them, all of these things. And what do I do? In those settings, that's where I talk about the importance of clinical trials, for colon cancer. That's where I talk about colon cancer screenings. That's where I talk about my horrible story of surviving colon cancer and my grandmother's story, and how this is a story that gets repeated over and over and over and over and over again. And I have found without fail that if you are in those settings and you're in some flagship luxury brand store and you are being wined and dined, that is the best space to be able to talk about something that is so horrible that most of us don't ever, even if you're healthy, you don't want to think about it. But if you've got a Louis Vuitton bag hanging off your shoulders and you are drinking a bottle of Moet Hennessy, honey, they will listen. And I have seen it. Even during the pandemic, we did virtual events where those products were mailed out to these people a few days before the event. And we had over 100 people each time when we had an event. So it can be done. You just have to, you've got to go to where these folks are and be there as a, just like what I had with all those doctors, holding my hand through that entire process. There was even a residence that was there, and she was a psychology, a psychiatry resident. And she was just there to observe me during surgery. And she told me so. So all the other surgeons are around and they're getting me ready. And I'm gonna just make this super short. All those people were there and they held my hand through that entire process. So I was just never alone.
Yeah. Thank you, Bridgette. We really appreciate the story. It's amazing. Let's go to, we have two last questions and then one kind of closing piece. So Dr. Guerra, we'll go to you. So there are so many audiences that come to mind when we think about equity. You know, you guys all have, ladies have all touched on the racial, economic, language, rural, just to name a few. So what do you think are, and Bridgette just talked about one of these potential partnerships, but what are potential partnerships that are important when we think about how we serve everyone equitably?
Great question, because I think that as much as we would like to, we can't do this alone. And so I think for the Colon Cancer Alliance, I think it's really important to establish the partnerships that will help us do that. And what are those partnerships is your question? I would say that for us, we try to identify who are the trusted messengers in each community. Trust is not easy to just acquire, even though you might have the best of intentions, like in our case as a cancer center. And so finding those individuals, and what we have found is that they vary. It depends on the communities that you identify that you're going to work with. And so for us, the Black communities around Philadelphia, for us, it's been the faith-based organizations, the churches that serve our Black communities. And so for us, that's probably been one of our ideal partners, because they really care deeply about increasing access to care as much as we do. And then the second thing I would say is, once you identify those partnerships, I think it's really important that you don't come to the table saying, I know how to fix this problem. You have to have cultural humility and be willing to listen to your partners about how they think they should perhaps, close the gap on colorectal cancer screening, because they're closer to the problem than you are. They're deeply impacted by that problem. And so they will probably know better ways than you can design on your own. And so if you're willing to listen and to invite them to offer those really great innovative ideas, I think it'll be a winning partnership. And then what we need are the resources to make up, to really fund those ideas. And that's, again, where the Colon Cancer Alliance comes in.
Yeah, I think this cultural humility piece, Dr. Guerra, is so incredibly important. I mean, obviously speaking as a white man, I didn't experience a lot of the things that others have. And I think for me, it's constantly trying to learn and figure out how we can support in different ways. So thank you. I really, really appreciate that. Dr. Issaka, so the next question is about, us, or kind of like just the general us. So we're committed to doing this work, as we've all been talking about, but we want to make sure we're seeing impact. And it's one of the reasons why I continue to ask that question about the makeup of the 20% and the 35% specifically for African Americans. But how do we measure and scale impact in colorectal cancer equity?
Before I answer that question, I wanted to also add that, once, to Dr. Guerra's point, once you have identified those trusted partners and, you are working in collaboration with them, it's, agencies like the CCA are really critical for funding that work. And I say that because the National Institutes of Health, which is the main mechanism by which many of us receive grant funding for our work, does not actually compensate individuals who we partner with in community to execute and change these numbers. And it's really quite unfortunate, but this is where organizations like the CCA can make a significant difference. So I just wanted to highlight that as a huge area of need. How can we measure to scale? I think the first thing is we cannot change what we don't measure, right? And so for many years, there have been interventions or outreach that have been done, and we really have no metrics whatsoever around their impact. So I would say with the CCA and sort of the partnerships you've already engaged in around distributing FIT kits, for example, keeping track of how many of those are going into the communities and how many are specifically being delivered to communities that are disproportionately impacted by increased mortality from this disease. So how many are going to Black communities? How many are going to those who are uninsured? How many are going to rural communities? How many are going to individuals for whom English is not their first language? And then also tracking those individuals to completion. So of those who obtain the kits, how many complete it? And if let's find out that that number is really low, are there ways that the CCA can go in and gather information to understand why somebody might have taken that kit but then ultimately never completed it? And then for those who do complete it, then measuring how many of those then with an abnormal result ultimately went on to get a colonoscopy, how many were diagnosed with colon cancer, how many needed resources, was their care, stopped in any way because of resources that they needed around wraparound care? And could there then be opportunities for the CCA to intervene in all of those different measures? So that's just one example of ways that we can measure very specifically the work that the CCA is doing, and then using that information to inform what is done next. And again, this work is not, possible without the generous, donors who contribute to this organization. So I want to highlight that and thank you all for that.
I really love that phrase. I don't know if I've ever heard you say that. We can't change what we don't measure. I mean, it's very simple, obviously, but it's so true. And, it is also an expensive endeavor to measure oftentimes, right? Yes, you can measure baselines, et cetera, but, in studying the Truth Campaign and the anti-tobacco campaign for teen smoking, I know they invested about $100 million in their first campaign. And of that, $20 million was used to measure their success. And it has forever stuck with me, because that's 20% of every dollar that potentially is going to measure. But, they reduced teen tobacco smoking by something like 20%. So it's really, really amazing. Well, we are almost at time, so I'm going to ask each individual to, and maybe Dr. Guerra, we'll start with you, and then Dr. Issaka, and end with Bridgette. Again, why do you do this work? What does it make you feel, and why do you do it?
For me, I want to thank Bridgette, because she talked about the many injustices in our Black communities that have occurred throughout history, and I can't not do it. I cannot do this, I cannot just stand by and not try to make things right. And so for me, it's a social justice issue. And MLK said, injustice anywhere is a threat to justice everywhere. I strongly believe that, and I want to do my part.
For me, it's really my community. I think about the fact that I've had relatives who would not want to undergo colon cancer screening until I myself became a gastroenterologist. Like the fact that it took me being that person in that stead to translate the benefit of what this meant. And for every Black patient I encounter, for every Hispanic, every Native American, Alaskan Indian patient that I encounter who says, nobody ever explained it to me in this way. And then that leads them to make this decision that could be life altering, not just for them, but for their entire family and for their community, knowing that that could start with, just that simple interaction is what really informs my work on a daily basis.
Thank you, Dr. Issaka. Bridgette.
For me, it's knowing that this is a disease that if it's caught early, and the only way that you would know that it's caught early, you have to screen, that can save your life. Knowing, like when I told my youngest brother when I was diagnosed, and he was just so afraid, more so than I, that our grandma died a few years ago, and now my sister is going to die. And I kept telling him, nope, the doctors are telling me this, and this is what they're doing, and, I had surgery and I was fine. But it took him a while to get to a place where it took past 5 years, even though I was going in for screening and surveillance, it took him to get to the point where we were like, actually about when I was pregnant with my daughter. And that's when he was like, oh, well, you're going to be here. People need to know that this is something, it could be devastating for sure, but it is something that is survivable. And so when I look at what has happened in my life over the last 25 years, and I did not set out in my life as a young adult to be in this space and doing science, colon cancer, and law. This was not my dream at all, but it is my purpose, because everything that I have done once I stepped over into this space, it's just been one godsend after another. It's been, I don't want to say easy, because I don't want to disrespect the blessings that God has given me, but it hasn't been a struggle.
Yeah.
Not like in my other work life.
Yeah. Thank you all. I feel like I'm blessed to be able to work with all of you and see your leadership come through. And, having lost my mom to this disease, I just, again, say thank you for helping to save, especially the most vulnerable among us, lives. There's nothing better. And thank you, everybody else, part of the Colorectal Cancer Alliance community, for listening, and have a great day, everybody.
Thank you.
Thank you.
Bye, everyone.
Thank you.
Bye-bye.
Thank you, ladies. Have a great
welcome.
one.
Thank
Appreciate
you.
all of you.
Thank you so much, Michael,
Thank you.
for the opportunity.